Well, good afternoon, everyone. I think there's some folks still coming in, but I think we're ready to get started. I am Shelley Ellis. I'm the director of the ICTR Dissemination and Implementation Launchpad and a member of the faculty in the Division of Oncology, Hematology, Oncology, and Palliative Care. I'm thrilled for you all to be here today to be part of the Implementation Science Seminar Series. If you don't know where you are, this is a monthly interactive seminar series that we host from the Dissemination and Implementation Launchpad. And this year, we're focusing on four pillars of the field: implementation theory, implementation methods, strategies, and implementation laboratories. This is where we do our work. Each seminar is held on the second Friday of every month from 12 to 1 Central Time and goes throughout the entire academic year. Our seminar is open to everyone, and it's also part of the Implementation Science and Community Health Outcomes Certificate Program, which addresses the gap between basic research discovery and their application in clinical and public health practice. So we certainly encourage folks, if you're interested in learning more about implementation science, the Implementation Science Certificate Program is a great way to do that, and it's available to people who already have terminal degrees as well as grad students and professional students. So it's my distinct pleasure today to introduce my friend, Dr. Sarah Birken. Sarah is Associate Professor in the Department of Implementation Science at the Wake Forest University School of Medicine. She studies change in healthcare organizations with the objective of improving conditions for patients, healthcare professionals, and their communities. She brings to her research, teaching, and service a deep understanding of how power, politics, and technology impede or facilitate organizational change. In research, Dr. Birken seeks to understand how organizational change can promote access to high-quality care. In team, she aims to shift learners' focus to the complex systems that constrain patient and healthcare professionals' behavior. In service, she helps to identify system solutions to deeply embedded barriers to meaningful change. Her research has been done by agencies including the National Cancer Institute, Agency for Healthcare Research and Quality, and the Centers for Disease Control and Science Prevention. Her work has been published in journals like the Journal of Clinical Oncology, Implementation Science, and Medical Care. She's served as an expert consultant for policymakers, including the American College of Surgeons Commission on Cancer and the Chilean Public Health System. She serves on the board of directors for two organizations that seek to reduce food insecurity, Fuel Up for Kids, and the Center for Food Equity and Prevention. Dr. Birken currently authors an important Substack, the sarahbirken.substack.com, and regularly speaks in professional development seminars about thriving as a woman in academia. And I just want to say that Sarah is also an inspiration to me. I've been in recent meetings where the impact of the work she's done in implementation science has been phenomenal. And I'll just give you two examples. I was attending an American College of Science meeting, and the work that she had done around rural healthcare delivery and improving cancer quality of care had actually motivated the American College of Surgeons to change their accreditation structure to be more inclusive of rural cancer programs. And it's just amazing to me to think that implementation scientists can have that kind of impact to actually provide policy and structural change that will improve the healthcare of rural Americans. And then earlier this week, I was at a meeting of the Wake Forest INCOR research base and found another example of the impact of the work that Sarah has done. She's actually participating in Design to Study, in which I had just been presenting the challenge facing cancer care delivery research, that the methods that we use sometimes are very different and not aligned with the clinical trials infrastructure that we use to do as our implementation laboratory. And Sarah's designed a study in which she's trained research creators in community oncology practices to gather qualitative research. And study coordinators were standing up at the meeting, admiring this study, telling people there exactly how much they loved participating in this and they loved learning qualitative methods. And again, it's just another great example of how Sarah has really changed the field and is amazing work. So with that glowing recommendation, I'm going to turn it over to Dr. Sarah Birken, and she's going to talk today about theories, models, and frameworks in implementation research.
Yeah, that was literally by far the nicest introduction I've ever received. So thank you so much. Yeah, it's great to be able to work on things that are actually driving change. And yeah, it took a long time to get there. I am going to talk about theories, models, and frameworks today. And um, I understand that many of you are interested in theory development, and that is so great. But as I was telling the team before you all came on, um, I never learned in graduate school how to select a theory, how to apply it. I took a theory course in my multiple theory courses. I know a lot about a lot of different organization theories in particular, but it was when I was um, taking my comprehensive exams, the question asked me to select and apply a theory to a topic. And I had zero experience doing that. I could tell you about a lot of theories, but I couldn't tell you how to select from among the many I had learned about, let alone how to apply that to a research question. Um, and I think I probably have ventured into this area of study because of the shame I felt in that experience and wanting to kind of own it. And it turns out it's not nearly as intimidating as I thought it was. And it's really the foundation of everything I do. So all of the kind of practical benefit that I try to bring to my work, that's really rooted in theories, models, and frameworks. So with that, I will, let's see, get over to my screen. And I'd like to acknowledge several people who have contributed to the development of these slides, contributed ideas and contents. So many of you may have heard of Per Nilsson. He is a researcher in Sweden, whom I've collaborated with. And we came together through a shared love of theories, models, and frameworks, or interest in them. Louise Hull also does a lot of methodological development. She's at Leicester University in England. And Cheyenne Waggy is a research associate at Wake. Alexandra Greenberg, also at Wake, a project manager. And Alexis Kirk was my graduate student and has moved on out of the research world, but just continues to think really interesting things about implementation practice that really inspires a lot of my work still. So they contributed to these slides. Okay, so I thought I would begin. Well, first I want to say that I'm only looking at my own screen, so I'm relying on other people to let me know if there are questions in the chat or if you are just bursting and want to ask a question at any time, please feel free to come off mute. We can be um, informal, but also we'll have a little bit of time after um, for discussion. Um, so it is kind of weird to give a talk, though, having no finger on the pulse of how it's landing. But I'll rely on you to let me know if things aren't going well. So you may have seen what is currently on the slide, which is a model from Enola Proctor, who kind of is laying out the relationship among the outcomes that we're interested in and how implementation fits in. So, not too long ago, in 2009, the concept of implementation outcomes was pretty foreign to people. So, right smack dab in the middle of the screen, um, she was making the point that there are these kind of intermediate outcomes well before we see the client outcomes that we focus so much of our grant-funded studies on moving the needle on, that we need to pay attention to these antecedents to those client outcomes like satisfaction, function, symptoms, morbidity and mortality. And that, of course, there are these kind of service outcomes as well. But prior to that, it's the implementation. Um, so this is the goal, right? To improve the patient outcomes. The problem usually lies in inadequate efficiency, safety, patient-centeredness, and we're trying to intervene on those problems with these intervention strategies. So these are the 7 Ps. Maybe you've heard Ross Brownson talk about, pills, policy, procedures. I can't think of all of them, but these are things that we think are going to improve these things. Um, and historically, implementation science I have seen defined as the scientific study of the effectiveness of these implementation strategies, which are these things that we think of as means to integrating whatever this intervention is into practice. Um, I take issue with that definition. I think it is overly narrow, but I can talk about that in a bit. Um, and what I think is really inspiring to hear from the planning group is that it sounds like people are in your cohort are thinking about how do we uh, why do we think these implementation strategies will improve implementation outcomes? And that's inspiring to hear because for most of my career and still most of the implementation strategies I see tested in papers that I read or proposed to be tested, um, it's not articulated why they've been selected to improve implementation. We require a lot of preliminary evidence about the interventions that we're testing in empirical study. But there doesn't seem to be that same level of requirement around how we choose the things that we do to improve the implementation of those things. I was inspired in part by these concepts by a conversation that I had with Karen Emmons, who's at Harvard, where she kind of made the point that implementation strategies are as burdensome as these interventions. You may see my cat in the background. She's going a little crazy. Um, um, and it's burdensome on busy practice staff. So I want to acknowledge her as well. Okay, so selecting implementation strategies. This is an idealized view of how we would do this. And I put this asterisk on strategies because instead of kind of the Eric compilation of strategies, I'd like to encourage people to think of strategies more broadly, including adapting the intervention, actually getting rid of the intervention altogether and choosing something that people in the context think is more relevant for them to solve the problem, if they think it's a problem at all. Um, and also that you can modify the implementation context. You can modify workflows. These are what I think of as endogenous implementation strategies instead of the kind of exogenous ones that we think about, like facilitation, audit and feedback, training, you name it. Okay, so ideally we would identify the problem, like what is the problem that clinicians are grappling with, that administrators, staff, patients are grappling with. And then we would go in and we would look at what are the things that are contributing to that problem and thinking about how we might intervene. And then we address those things with strategies, and then we test them. That's not really how we do it in implementation science for the most part, unfortunately. Okay, so there's a theory. Here's where I get to the topic that we're talking about today. There is a theory model and a framework for all of this. Um, when you are thinking about what's the problem in practice, why are providers not doing what we want them to do? Why are patients not getting into the clinic? Why can't we get front desk staff to consistently hand the iPad to the patient? Um, we can think in terms primarily of frameworks. And I'll talk about what they are, but they cast a wide net about all of the things that might be influencing the problem or contributing to the problem. Process models kind of help us think through, okay, how are we going to get this to happen? And how do we think this is going to go? And having a plan for that. And then you can assess the extent to which those strategies worked using evaluation frameworks. So I'll go into a little bit more depth. So these slides are directly from Pear. Um, I might have modified them over the years, though. So uh, there are so many theories, models, and frameworks in implementation science, just a huge amount. It's overwhelming. And when I started my career, this was a big topic of interest. And so Pear wrote this article making sense of implementation theories, models, and frameworks. It's really fantastic. I hope you've read it. And he basically provides this structure. So all of these kind of theories, models, and frameworks, and he talks through, okay, if you're describing or guiding the process of translating research or evidence or any intervention into practice, you're using a process model. Um, if you are evaluating how that went, you're using an evaluation framework, ideally. And if you're trying to understand or explain what influences adoption, fidelity, the consistency and proficiency with which the research, the um, intervention is being used, you're going to a determinate framework or a theory, which I, in all cases, think is important. But I'll get to that in a moment. There are classic theories that we draw on. I often draw on organization theories because that's what I was trained in, and I study organizations. Um, and then there are several implementation theories that have been developed in the field. So it's really important to note these are totally different things. In particular, theories are quite different from models and frameworks. Theories predict or explain the causal mechanism of implementation, whereas models kind of sketch out a process and frameworks are that wide net. Okay, I came up with an analogy a few years ago that I think is useful. Theories are like a weather prediction. They ideally are the framework, the frame on which evidence is laid uh, regarding hypotheses posited by a theory. We think X influences Y, and then we generate lots of empirical evidence. Did X cause Y in this setting, in that setting, in the other setting? Okay, here's what we think is going to happen in the next setting. Models are like maps of how we think this is supposed to go. They get everybody on the same page about the structure of what's going to happen or what did happen. And frameworks are, I think a physician once told me I got this wrong. So, but really just kind of trying to get a sense of what might be going on. It's a diagnostic tool. I think this is a diagnostic tool, an MRI, I think. Anyway, Okay, so going back to that framework of the steps in an ideal world. Actually, I'm going to pause. I'm going to I'm going to drink some water and um, see if anybody has burning questions. Yeah, Emily.
Hi, I'll pop on. Here it is. I'll pop on my camera so you can see me. Yes, so I know you're going over this, and I might be putting the cart in front of the horse, but when you were talking about the process model and the evaluation framework, and then your previous slide that had all of the different arrows going, they didn't connect, but they sound like they should connect in my brain. Yes, they sound like they should connect in my brain. And I know you're saying that they're different, but I almost feel like they need to have one or with the other. Can you kind of explain that, or do you use
Yeah.
one,
Yes, I'm a big proponent of using everything and anything and everything. And in my work, I use all of them for every study. Not because I have a rule about that, but because they're useful. So I will talk about that. But feel free to pipe up if you want more clarity.
Okay, thank you.
Sure. Okay. I'll forge ahead. Um, and I'm going to draw on a couple of studies to kind of talk through how I do this. So, um, uh, um, the first step is to kind of figure out like what's the problem we're trying to address in practice. What's happening. And an example from actually the study that Shelley mentioned is health-related social needs screening. We know it's not happening proficiently or consistently in practice for the most part. And we know that because we've done EHR data polls, we've done surveys of practices, um, that sort of thing. So why? Why are we not doing health-related social needs screening in an optimal way? That's actually the study that Shelley mentioned. That's what we're doing. We're having these research coordinators use a determinant framework, although we don't, well, we kind of talk about it, but um, we're asking them to cast a really wide net to get a view of the forest of all of the things that might be contributing to health-related social needs screening not happening. And if you think in terms of the consolidated framework for implementation research, which I hope you are at least a little bit familiar with, at least in name, it kind of has these domains of factors that we think might influence implementation. Um, and we are using an interview guide for these research coordinators to go to practice managers to ask them about, like, of all the things that might be affecting the implementation of this screening, what's going on here? Um, so I often will use a combination of the consolidated framework for implementation research and the theoretical domains framework. And the reason I do this is because um, I think of the consolidated framework for implementation research as getting primarily at like what's happening with the organizations with a little bit about individual or team characteristics, but not much. And so the theoretical domains framework drills down to uh, domains related to individual behavior. So an example of when I've applied the theoretical domains framework is in this study. There are studies out there that are very careful, and implementation science is pretty specific about they want, theory anchored work. And so you can kind of please, if you, I think that this is a very high quality application of a framework. And so feel free to like borrow and tweak our methods, or probably want to look at something a little bit more recent. And look who's there, Shelley Ellis. Um, so but then to, I think it was Emily's question, that we do want to transition from the forest to the trees. We want to go from this wide net of like what is potentially going on here to a story about how all of the things that are influencing the implementation of whatever it is in that context, why we think that's happening. It's a diagnosis. A theory is a diagnosis. It's saying we think this is the phenomenon. We think this is the condition. And so, in I'm just making this up. Let's say that there's, issues of like a poor implementation climate, but there are these accreditation standards, and people know about it, but they're actually not getting reimbursed for it. And uh, the way that patients flow into the organization is not conducive to um, the use of a health-related social needs screening tool or process for then following through and addressing those needs. And at the intersection of those things is a story that I think one of my favorite, I want to say, let's see if I can remember who it might have been, like Barry Starr. No, it was somebody at Michigan at any rate, in like the 80s, said that a good theory should delight. Theories should be simple. And I like to think of theories as delighting because they're kind of familiar. Like we know this phenomenon. We know these things happen. Um, so um, let's see if I can come up with a recent one on the fly. Um, a lot of my work in navigation, patient navigation around health-related social needs, for example, like financial hardship, is really rooted in transaction cost economics theory. It's this idea that there are costs associated with coordinating across multiple organizations. Um, and any effort and the best intervention to reduce the friction associated with um, coordinating across, like all the work that has to happen to coordinate across organizations, is done by some centralized feature that is like a clearinghouse of information and kind of can mediate among all of those different organizations. Transaction cost economics theory is really useful in that sense because it tells us why we think a navigator works. And if we know why we think a navigator works, then that kind of tells us what are the things about that navigator that can't change. And one of those things is we can't have multiple navigators. We have to have one person who's the point person for the patient because that needs to be a single connection. So that's just an example. So moving from frameworks to theories is critical for identifying strategies that are actually going to act upon the mechanism. Okay. So how do you choose those strategies? I kind of talked you through the application of an organization theory. There are, let's see. So these psychological theories, I think this is a link. I'm happy to share my slides to like the application of the theoretical domains framework. If you're using the theoretical domains framework, the behavior change wheel is a tool that maps from the determinants that are listed in the theoretical domains framework onto behavior change strategies. Beautiful. Context-driven co-design is the method that is used in the study that Shelley mentioned. And it is an approach for kind of walking from, okay, what's the problem here and why is it happening, to what are the strategies that are most likely to act upon those mechanisms. There are things like the Center for Implementation has some really good tools. And then, in the study, you want to find out, okay, did it work? So in this other study that we're doing, we went through context-driven co-design to design the strategies together, redesign workflows, engage leadership, all the things, put up signs about what the heck is going on with this health-related social needs screening, ensuring that it happens in such a way that the patients feel comfortable disclosing information, that it's clear to them what will happen or won't happen if they do talk about these things. We had a 3-month period of those strategies being in effect. And then we're doing a data poll, an EHR data poll, to look at, did that improve adoption of the health-related social needs screening tool in that clinic? And we're using REAIM. How many patients did it reach? How many providers was it adopted by? Across patient populations, was the reach equitable? So that's an ongoing study that we have. Okay. I'm going to talk through really quickly about selecting implementation theories, models, and frameworks. How do you choose them? This is a tool that I don't recommend you use anymore. It's been improved upon. Let me go back. So this is actually a very useful website, dissemination-implementation.org. It's a tool for kind of thinking about the different things that you're looking for in a theory, model, or framework. But the best tool I think is available right now was just published earlier this year, and it's called the Select It Meta Framework. And it really kind of walks you through how to select a theory, model, or framework for your particular project. Highly recommend. This is the best that I've seen so far. Okay, but if you don't want to get that technical, if you don't need to get that technical, I think it's useful to do all of these things. But you really want to think about, what are you trying to do? What research question are you trying to answer? That will tell you whether you need a process model, an evaluation framework, a determinants framework, or a theory. But just talk to people about it. Look at extant research that has been done on your topic to think about how they framed this work. And use the Select It tool. Okay. Really briefly, gonna go through applying theories, models, and frameworks, and then we'll have about I guess 20 or so minutes to chat. So this is based on work by Alexis Kirk, who was doing for a class in graduate school a systematic review of studies that had used the consolidated framework for implementation research. And what she found was that the way in which it was used was very poor. It just was not as it was intended to be used. So I suspected that that might be the case when she started the lit review, because I had a project officer once tell me that she had received an Ames page that literally said, insert theory here, in the context of the rest of their Ames. Like it was an afterthought. I mean, it was literally an afterthought. They were going to think about it after the proposal was written, which makes me want to pull my hair out. In my opinion, theory should be part of the entire process of research. So you're going to want to explicitly justify your selection of theories, models, and frameworks, and integrate it throughout the project. Research, it can motivate your research question. If you're testing a theory that motivated your research question, it can help inform your study design. I'm going to focus on talking about how it can help you collect data and analyze it, mostly here. So every survey I do, every interview I do, focus group, any data collection I do is based on some theory, model, or framework. It is a way of being comprehensive and reliable in thinking about the phenomenon in a way that stands on the shoulders of giants. People have thought about the topic that you're investigating for a long time. Or some angle of it. So you get to rely on their knowledge, the knowledge that they've produced by kind of anchoring your data collection in what we already know. Um, so this is from a very, very old study that I did, and I used, I think it was like the theory of planned behavior or something. I guess that's what's at the intersection of this, maybe, or the planned belief model or something like that. But I literally created a table to kind of talk about which interview question was linked to which construct. And I recommend that you do that. Um, yeah, yeah, I think this was the theory of planned behavior. So again, with this survey that I conducted, item by item, making sure that my survey, before it goes out to all of those people, is comprehensive in its treatment of the phenomenon that I'm studying. Why are providers not using survivorship care plans? Um, you can also use theories, models, and frameworks to guide your data analysis. So for qualitative methods, it's pretty straightforward, thinking about um, you know, the constructs in a framework or theory or a model as codes in for the qualitative data. For quantitative analyses, you can use theories to think about what factors should be included in your analysis. I'm realizing not everybody is familiar with configurational comparative methods, but you should be. It's a very compelling method. But you can also think about like mediation is an interaction term in a quantitative analysis. Theory can help you hypothesize mediating effects. Instead of X just affecting Y, we can say that X affects Y through Z. And that is a way that you can apply theory. So this is just an example of coding in Atlas TI a million years ago using, I think this was, yeah, these were actually Eric strategies that I was coding with. So I'm gonna skip ahead just to say that don't finish your manuscript without reflecting on the similarities and differences between what is in that theory, model, and framework and what you found. That is the only way we develop theory, is in this incremental approach of saying, I'm bringing this empirical data to bear on this theory, model, or framework. Here's where it's consistent. Here's where it's inconsistent. What does that mean? Does that mean that my empirical setting was an aberration? Maybe. Does it mean that the theory was wrong? Maybe. So that's a compelling thing that I don't see enough in manuscripts. Okay, I'm going to skip ahead and just end my little spiel with this. So I don't hold any theory, model, or framework precious. I don't have a favorite. I probably overuse some and underuse others, but they're just tools. No tool is perfect. It's to get the job done. Some tools are sharper than others, but it's really not, you're not trying to approximate reality. You're trying to kind of be transparent about the way you're looking at the world. And so I end with this, that theories, models, and frameworks should not be an albatross around your neck. They should give you wings. Make the tools work for you. And with that, I will stop sharing and open it up.
Thank you so much, Sarah. This is fantastic. And I feel like very validating. I feel like I gave some similar advice recently to somebody about, using theory throughout the process. And probably also don't do a good enough job just thinking about um, reflecting on the theory when I'm done and like, what did I learn from the theory versus, or how does this change the theory? And I think that's really helpful and useful advice. So I want to invite folks in our audience. We have a wonderful group here today, and if you have questions, you can either type them into the chat, and we'll try to address them there. But also, if you feel like if you have a question, you want to unmute and ask, that would be also perfectly acceptable. And so. One of the things that you mentioned, I was going to ask you what your favorite theory, model, or framework was, but you, spoiler alert, told us you did have one. But I'm just thinking, one of the questions that one of the students brought up was, how do you, when you're thinking about expertise and a team and designing a project, sometimes folks have more familiarity with some theories, models, and frameworks than others. Let that drive how you select theory. Um, do you think about the expertise and capacity that you have within your team, or do you have to go for and think about it a
Yeah,
different way?
I um I am pretty um um probably a little too like trigger happy with reaching out to people and just being like, "Hey, I see that you published a lot on, so that's how I got into the theoretical domains framework. Actually, embarrassingly, I think I even like emailed Susan Mickey, who developed the theoretical domains framework. Just being like, "Hey, can you help? I learned about this and I'm interested." And that's how I struck up my collaboration with Justin Perceau, who is at Ottawa uh, Hospital Research Institute, um, because he has done a lot of work in the theoretical domains framework and health psychology. And so I try to be as expansive as possible in my thinking about things. Um, and I think that's why I feel really strongly about not holding on to any theory so tightly, because sometimes I do come across phenomena where I think like, I don't even know how to think about that. Like, who studies group behavior or whatever? Yeah.
So, do you find yourself searching out theory, being like, if you decided that something was around a phenomenon that you're studying, the clinical issue is around a problem with group behavior, um, what would be your next step? Like, how would you take that to finding a new theory that you hadn't thought about before?
I'd Google. I'd put in a bunch of, search terms and start to kind of drill down and um, asterisk Google Scholar much of the time, but not always, and kind of drill down that way and kind of I try to be respectful of like as reckless, and I am reckless with theories, models, and frameworks in the sense that like we're not doing surgery here. Like I can, get it a little bit wrong and somebody will correct me and nobody dies. But it's ideal to talk to somebody who's used it before and who kind of has thought about this um, in a nuanced way. I again spend a lot of time around organization theories and I feel pretty proficient in their application, but not all of them. And so like um, I reached out to a researcher who does work on collective mindfulness and theoretical work in that. And yeah, I mean, I can read about it, but to kind of work with somebody who thinks about it in thoughtful ways is useful. Um, I see that Paula has a question.
Mhm.
Um, I've been
Wondering if she
thinking,
might want to open up her mic and pose it.
yeah, that'd be helpful if you're comfortable with it.
Yeah, of course. Can you guys hear me?
Mm-hmm.
Yes.
Okay, awesome. Yeah, thank you so much. This is a great presentation and a good reminder of some of the basics, that we've learned. So thank you again. So yeah, I've been thinking a lot about the role of design in translating strategies into designed things. And I kind of put this in the question, for example, education and training, if we decide that's relevant because there's a knowledge gap, it could be operationalized in, 1,000 different ways, depending on, the context and the people. And so I'm curious how you have found working with, design folks, so user-centered designers, human factors engineers, to ensure we're also reflecting best practices in design. So like maybe sometimes it's actually not the implementation strategy that's failing, it's the design of that implementation strategy. So I'm just curious how you've kind of dealt with that over your career and maybe like some thoughts you have on that. Thanks.
Yeah. So, my relationship to user-centered design is through Emily Haynes, who's an assistant professor here at Wake. And she uh, developed expertise in that topic through her graduate work. And we incorporate that into context-driven co-design. It is entirely possible that, I'm thinking about this study that we did to facilitate the implementation of health-related social needs screening in a supportive care clinic. Um, and we, for example, one of the things that we decided needed to happen to facilitate implementation is to put signs up so that patients and also to verbally have the medical assistant talk about why is this happening, what will happen with this information. Um, and it's possible that the design of those signs, not their existence, was didn't help because they weren't optimally designed. The messaging wasn't right, for example. That certainly is a possibility, and I would certainly appreciate engaging people who do this um, in a more robust way. Um, so I think there's an opportunity there for sure.
Okay, awesome. Thank you so much.
Thanks, Paula. Emily, I think you have a question if you'd like to have the floor to ask it.
Yeah, so I'm an occupational therapist by trade, and I have found that sometimes people are not super receptive to asking questions, because, we just have a lot going on our plates, and sometimes you just have to be mindful of that. And so have you ever found that there's an unspoken rule or, just a time that's better than others to reach out to other professionals that you may have questions, specifically in research?
Yeah, uh, I I'm sure I've gotten as many non-responses as I have gotten responses, and I try not to take it too personally because of what you say. People are busy, but I've I I found people to be quite generous, and I've never not been able to find somebody who wants to help. It might not be the first person I reach out to, but of the many wonderful collaborators I have, it's really nice to find people who are excited to think about whatever you're interested in. And if they're not interested in thinking about that or helping you with that, but I don't think there are any rules, or maybe there are and I haven't followed them. But I think it's always okay to reach out to somebody and say, you know, I I'm interested in your work. I would like, and having a clear ask. Um, I think that's kind of what our job is as scholars, is to do that together.
Awesome. Thank you.
Yeah. And I see Brian is asking about how do I balance fidelity with adaptability in the use of a theory, model, and framework. Um, it's a good question, and I um, am very reckless. I just, I don't introduce, I shouldn't say that I'm reckless, but I am not careful. I, uh, I think that if you are testing a theory, if you are testing a hypothesis that a theory proposes, then you should be very careful about the way you measure those constructs, because you're bringing to bear evidence about whether or not that hypothesized relationship is in, whether there's evidence to support it. And that is a serious thing. Um, but, when I develop an interview guide, I don't use every construct of CFIR in every domain. Sometimes I don't use every domain. If I have good reason to believe that a particular domain is not relevant to this question. Um, I see lots of people modifying process models to include different things. I think that they're made to be modified. And I guess I kind of like started my career by modifying an existing theory. And I think that that's a good thing.
Thank you for that. And it's funny that you mentioned CFIR. That's the one I'm talking about. We're in the process of starting our analyses, and I'm like, oh, it feels so painful to remove a construct, but I thank you for that permission.
Yeah, yeah,
To do it
absolutely. I mean,
thoughtfully.
if especially if you're not seeing anything in there that is related to that construct, then it's not relevant. I mean, good thing it's not relevant, because if all of the things in the CFIR were relevant to every problem, we would be, I mean, how would we ever solve any problems?
Thank you.
Sure. And I see Paula has this question, quality in theory model. Oh, okay, that's cool. Oh, interesting.
Paula, do you want to talk about the paper a little bit?
Yeah, sure. I'm not actually involved in the paper. It's just some colleagues I had back at University of Toronto, but similar to the paper that you shared, Sarah, about selecting frameworks, I think they're digging in more into like what it means to like have to find like a framework that is quality for your specific research purpose, and then how to use it in like a quality way and what that even means. So they're kind of delving into that. And I
Cool.
think they did a scoping review, but I think they're publishing a few more papers in that area. And it's just, yeah, it's delving into some of those conversations around how to choose, why you're choosing different frameworks. So just something to keep out. I can't speak too much to the research itself, but I know they're working on that.
Yeah,
Thanks for
this
bringing
is
that to
super
our
cool.
attention. Yeah, Kayla has a question. She's wondering at what point does a drastically modified framework become a new framework altogether? So, if you're doing the job that you mentioned and reflecting on frameworks and just thinking from your empirical data, like how the framework might need to be tweaked, um, or the theory, when do you rename it and call it a new theory, or
Yeah, I
where do
mean,
you
I
go from
guess
there?
I'm glad you asked the question, because I think I say that I'm reckless. I'm actually not. I mean, I am, in the sense that I'm like expansive in the way I think about how to use theories, models, and frameworks, but I always have a justification, right? Brian said, the construct wasn't showing up in the data. That is a very clear justification for not including that. For every modification you make, you want to have a justification, and make that explicit, in your write-up of the methods. But if you are making so many changes, if you need that many changes that it ceases to be what it was before, then you are then you're no longer using it. There's a point at which you're not actually using that theory, model, or framework, and you're justifying not using anything at all, using what's in your head. So, and it may be that there's just a better one out there that you haven't come across, and maybe you need to dig a little bit more and see if there's something more appropriate for your use. I mean, I don't think, we're not done developing theories, models, and frameworks, and also there's nothing new under the sun. I think both of these things are kind of true.
So on a related note, and looking toward wrapping up, somebody brought up a question. Is it ever, I just want to say, avoiding insert theory here kind of approach, but is it ever too late to incorporate into a project that's already moved forward?
Yeah, that's a really good question. And I would say no. I mean, I don't know if I've ever collected data without some theory, model, or framework to support it, but I've definitely recommended people analyze data that they've already collected using a theory, model, or framework. I mean, I think that can be really useful. If I got a manuscript that brought in theory at the very end to kind of comment on their empirical findings, I would reject it. So maybe it is too late at some point. Then I'd just be like, why didn't you use theories to begin with? But I'd have to think about that, because I'm sure there's an exception to that.
Awesome. Well, Sarah, thank you so much for being here and reflecting on this important topic for us. I think people were super engaged and really benefited from your experience. I would invite all the attendees to, number one, fill out the evaluation survey. We like to hear other things interested in learning about, and we like to make sure that we're meeting the needs of a wide swath of folks at UW. So please fill this out and tell your friends Implementation Science Seminar Series, and come back November 14th on our next session. We have all of our schedule for the year is on our website. And so please come back. And again, thank you very much.
Thanks for having me, everybody. Bye-bye.